My name is Samantha Irwin, and I'm a nursing student at Massachusetts College of Pharmacy and Health Sciences. I, along with two other pharmacy students, are working together on an interprofessional education project. Our patient is DK. She's a 48-year-old female. She stated that her chief complaint was, "My back pain is so bad where I can't fall asleep without taking my sleeping pills." Her history of presenting illness was she was put on an ACE inhibitor, but that didn't work, so the physician put her on amlodipine. She stated that the physician believed that her hypertension was due to genetics because she had no common precipitating factors such as lack of exercise, smoking, or poor diet. Our patient was also diagnosed with scoliosis. Our patient stated that the pain is mainly located in her hips and her lower back. She states that the pain distorts her posture and causes her to have a limp. She says that on normal days without pain medication, her pain is an 8 out of 10, and when she's on the pain medication, her pain is a 5 out of 10. She states that the pain is the worst in the morning and that the pain increases while standing or sitting for long periods of time. Our patient states that she occasionally uses ice in combination with her pain meds to help relieve the pain more efficiently. Our patient was also diagnosed with insomnia. She states that she has a lack of ability to fall asleep that she thinks is often associated with her back pain. She states that she is unable to fully fall asleep and states that she is in a surface sleep. Our patient denies being able to sleep without any type of medication and cannot nap during the day. She states that she does not use any other types of relieving factors to help aid her in her sleeping habits. Our patient's past medical history is that she was diagnosed with scoliosis when she was 12 years old. She also had a Harrington rod surgery when she was 19 years old. She was hospitalized when she was 29 years old to have the rods removed from the Harrington rod surgery because the rods started to move in her back. In 1996, she was hospitalized for a spinous process removal, and in 2011, she was hospitalized for a revision rod surgery. Our patient was also diagnosed with insomnia in 2007. Our patient states that her past family history was that her mother had a high blood pressure and hypertension. Her mother also had diabetes. Her mother also passed away from a stroke. Her father had diabetes type 2, and her sister had suffered from morbid obesity. Her grandfather and her two older brothers suffered from alcoholism. Our patient states that she was a former smoker and she quit 22 years ago. She occasionally partakes in alcohol use, but not often. She approximately has 1 cup of coffee per day, and she is married and lives with her husband. Our patient's review of symptoms was that our patient stated she was 125 pounds and believes she eats a well-balanced diet. Our patient states that she suffers from hot flashes and she also suffers from night sweats, which she believes are due to menopause. Our patient states she's often fatigued and has seen that she bruises more easily now. Our patient also states that she gets poison ivy every spring and she's seen an increase in dryness in her skin. Our patient states that she believes she has a normal appetite and that she has a bowel movement every 2 to 3 days. Our patient states that her bowel movements are solid, round, hard, small, and that she is often constipated. Our patient states that she uses Senna to relieve this constipation. For our laboratory data, we found that our patient had an EKG last December and that the results came back normal. We were unable to find any diagnostic tests with our patient.
Hello, my name is Jonathan Skoperort, and I am one of the pharmacy students for this IPE project. All right, so the allergies for DK, unfortunately, she does not have any allergies that she's aware of to any food or medications, and that brings us down to the medication list. Like Samantha previously mentioned, the patient is on lisinopril 10 milligrams. She takes that 1 tablet once daily, and then the doctor also added on amlodipine 10 milligram, where she takes 1 tablet once daily. The patient is also taking zolpidem 10 milligrams, 1 tablet by mouth at bedtime, and then for her back pain, she's taking oxycodone with acetaminophen, the 5-3-25 strength. She's taking 2 to 3 times daily as needed. And then she's also taking Advil 200 milligrams, 1 tablet every 6 hours as needed for lower back pain. And then additionally, for her headaches, the patient is taking Excedrin, and the frequency she takes about 3 to 4 times weekly just due to the fact that she experiences a headache about 3 to 4 times per week. Before the patient was on zolpidem, she was taking Excedrin PM, where she took that initially for 6 months before she seeks medical treatment for her insomnia, where the doctor eventually changed her to zolpidem 10 milligram. Okay, now to go to the problem list that Samantha and I came up with. The first problem, or the number one problem, is related to her chief complaint, and it's that she's unable to fall asleep without the aid of a zolpidem tablet. So we believe that the patient has developed a dependence on zolpidem and is unable to fall asleep on her own without the sleep aid. The second problem that Samantha and I came up with is that there's a therapeutic duplication between two of the medications that DK is currently taking. So the patient's taking oxycodone with acetaminophen, the 5/325 strength, for her pain, but then she's also taking Excedrin for her headaches. And both of these medications actually contain acetaminophen. This wasn't our number one priority on the medication problem list, mainly because she's only taking the Excedrin about 3 to 4 times weekly just due to the low frequency of her headaches. However, this is definitely a problem that should be addressed with the patient to make sure that she does not take those medications at the same time. Another issue that we came up with is that the patient needs additional drug therapy regarding her frequency of poison ivy outbreaks. The patient told us that she gets poison ivy once a year, which is something that definitely should be addressed because there are some creams that she can take. There's actually even oral medications that she can take for prophylaxis to help prevent getting poison ivy. Another problem that we identified is that the patient needs additional drug therapy regarding her dry skin. The patient said that her dry skin has actually gotten worse, and so we could actually recommend like a moisturizer to help relieve that. So the primary sign problem was insomnia. The subjective information is that the patient has been on Zolpidem for the last 7 years. She takes it every night about 3 to 4 hours after dinner. The patient said that her physical activity has been limited to walking a couple of miles a day, which varies on the time of year. And that the patient's chief complaint is that she would like to sleep on weekends without the aid of needing to take a Zolpidem tablet. The objective information includes that the patient's weight is 120 pounds, her height is 5'6", her blood pressure is 118/64, and her pulse is 64 beats per minute. The assessment of the patient is that DK is a 48-year-old woman who has been taking Zolpidem 10 mg for the past 7 years and has had difficulty falling asleep on weekends where she would prefer to not need to take a tablet. After lying wide awake upon attempting to fall asleep, DK must resort to taking half a tablet to help her fall asleep. So now I will discuss the plan for DK. First of all, I will talk about the goals of therapy. So the number one goal is to improve sleep quality. Number 2, minimize dependence. Number 3, minimize adverse effects. And number 4, educate the patient on proper sleep hygiene. Now the pharmacologic plan. So since the patient has been on Zolpidem for the last 7 years, the only medication for sleep that is actually FDA approved for long-term use is actually Lunesta. So this is why we came up with the agreement to change to Lunesta. And so we figured to start out at a medium dose, which is Lunesta 2 mg, and the patient will take that 1 tablet at bedtime. Also, Lunesta is a lower potency than Zolpidem, so this should potentially help the patient to have a less dependency on her sleeping medications. Along with that, Lunesta helps normalize the sleep architecture, which is helpful with sleep maintenance. So now I will discuss the non-pharmacologic plan for DK. So we will definitely educate the patient on proper sleep hygiene, which will include, first of all, stick to the same bedtime and wake-up time, even on the weekends. Number 2, practice a relaxing bedtime ritual. Number 3, avoid naps, especially in the afternoon, which that's actually something that the patient was already doing. She said that she rarely would take a nap, but that was still something definitely important to address with her. Okay, and then next, to exercise daily. However, the patient was limited to walking, which would depend on the weather as well. Next, to sleep on a comfortable mattress and pillows, and then avoid alcohol and heavy meals in the evening, and then avoid caffeine at least 6 hours before sleep. And then last, if you can't go to sleep, go into another room and do something relaxing until you feel tired. So now I will discuss the monitoring parameters for the Lunesta. So first of all, in order to determine efficacy, this is very subjective, so it's going to be based on what's reported from the patient. So we're going to look at improvements in sleep, onset, duration, and quality. And then in terms of toxicity and adverse effects, we will counsel the patient that taking Lunesta can cause an unpleasant taste, a headache, CNS depression, which includes excessive sedation, and impaired coordination. In terms of follow-up, we will have the patient follow up with the doctor in about 2 to 4 weeks in order to determine if the patient needs to increase the dose. So the patient education that will be provided to DK will include to immediately take the Lunesta before bedtime, just because it has a very rapid onset of action. Along with that, we will inform the patient to avoid taking the medication after a heavy meal, just because this can delay the onset of action of the medication. Also, we will inform DK to make sure to allow 8 hours of total sleep time before taking the medication. And then also, report insomnia that worsens or persists longer than 7 to 10 days. And then also we will make sure that DK is aware to not drink alcohol while taking Lunesta. And then also to take the drug only when experiencing insomnia, which that itself should definitely help with the dependence.
Pharmacy student from Manchester. I worked with Sam and Jonathan to work up our patient DK. And as Jonathan already focused on DK's problem list, allergies, and his individual problem, I'll move right on to cover my problem. I focused on DK's pain management. As for her subjective findings, her current oxycodone and acetaminophen therapy requires her to take pills around the clock, make frequent stops at her doctor's office for new prescriptions, and frequent stops at her pharmacy to get refills. Additionally, these tablets are causing her uncomfortable side effects, such as her constipation. She reports back and hip pain that's worse in the morning, and when she's not taking her medications, it's an 8 out of 10, and when she's on the Percocet, it's a 5 out of 10. She has a history of scoliosis and related surgeries that contribute to her back and hip pain. For objective findings, she's a 125-pound woman, 5'6", heart rate of 64 beats per minute, and her blood pressure is controlled to 117/80. She has a distorted posture and a limp related to the scoliosis and back pain. As pain is mostly a subjective finding, this is really it for the objective findings. We could also do a visual analog scale to see pain improvement with therapy or changes in therapy. For an assessment, it seems like DK's pain is only partially controlled with her current therapy, and it's causing mild to moderate discomfort for the patient. So my plan for DK is to change her therapy to include an intrathecal delivery. This would require using a pump to inject drugs directly into her spinal cord to control her pain a little better. This recommendation is based on a study by Deer and his colleagues that was published in the Spine Journal. They found that the spinal infusion therapy was effective at treating pain that wasn't well managed with traditional opioid therapy as well as surgery, and they found that the combination of an opioid analgesic along with the local anesthetic bupivacaine was very effective at reducing pain and the requirement for other drugs to control pain. The doses of the individual agents would be individualized for the patient to control for efficacy as well as safety, but overall it would limit the systemic exposure to the different agents and therefore the adverse reactions and toxicities associated with them. It would also reduce the supplemental oral or transdermal opiate requirement and reduce the visits to the doctor or ER because of the back pain. As far as monitoring for the patient, for efficacy, you'd want to make sure that they have improved pain control. You can rate this by the visual analog scale. Patient reports reduced use of opioid therapy for tablets or transdermal, and that can include opiates or any over-the-counter analgesics like ibuprofen or acetaminophen. And we should also see reduced constipation because of the reduced systemic effects. For safety, the major concern was with bupivacaine possibly causing neurologic effects. The study didn't find any, or the few that they did find were reversible, so we just want the patient to keep track of any edema, any paresthesias, neurologic signs such as decreased reflexes or muscle weakness. They just want to report that to the doctor. For our group work, it was a very important component of this project, as working interprofessionally can promote the development of many useful skills. As we also had to coordinate from Worcester to Manchester, there were additional challenges that made us work extra hard at making sure we worked well together. It was important for us to have good communication, planning, as well as teamwork skills, and as a group we were able to establish an effective means of communication, as well as establish roles and a schedule for our project. With our specific deadlines and objectives for each member to work toward, we were able to complete the project in a timely and efficient manner. This also crosses over into our professional field, as there are specific roles for the different disciplines as we get out into the working place. Having a good relationship is an important component of working in an interprofessional setting. For nursing, their role as far as interprofessional is to monitor for side effects, efficacy, as well as to being the last check for any medication that's administered to the patient. They also are able to provide updates and assessments of what is happening to the patient, along with recommendations for what they think the next step should be. It's important to have a good relationship with the pharmacist for a nurse, as they should always call with any drug-related questions or concerns. Calling can mean the difference between life and death for a patient, and it's very important for reducing adverse effects, allergies, and making sure that the correct therapy is picked for the patient. For pharmacy, we rely on findings from the nurses to determine appropriate doses as well as medications for a patient. And they're also responsible for being our final check before the medication goes to the patient. So you want to be sure that they're comfortable with bringing any concerns to us and preventing any medication errors actually getting to the patient. We want to be open and helpful for any questions they have when they come to us, because we want to make sure that they come with any issues and that we can provide the best patient care possible. By working together, we can promote the best practices and establish the best patient care possible. We can reduce the risk of adverse events, allergies, death, and just overall poor patient outcomes. The interprofessional project we worked on helped promote this continued collaboration and teamwork, and should help while we're out on rotations, as well as after we've graduated and are working in the professional field.